Yeah, I think so.
I think we're going to be pretty casual here.
We're casual.
Introduce from here, am I?
Yeah.
15 seconds of fame.
I think it's just because of the Hemp Olympics starting at the same time.
Which one is?
The Hemp Olympics are starting.
Oh,
right now,
yes,
so
yes. No, I noticed there's an awful lot of other things that are going on at the same time.
I'm keen to see your next talk as well.
And I'm talking again at 2:30.
Yeah,
So,
I'm keen to-
besides that, I don't need this for my ego, and it helps to keep me humble.
I'd like to welcome you all to Disco Sista's tent and a session with Dr. David Bearman, who's a physician, an expert witness and an author, and he's the author of a very interesting book, Drugs Are Not the Devil's Tools, and he's been a practicing cannabinoid medical practitioner since 2001, and his topic is cannabinoids, PTSD, ADHD and beyond, a clinician's effort to understand the brain, and it's some thoughts on why cannabinoids work for PTSD, ADHD and ecocannabinoid deficiency conditions, and there will be a question and answer at the end, so if you'd like to leave your questions till then, welcome Dr. David Bearman.
Thank you. It's a pleasure to be back here in Nimbin. I was here 2 years ago, and the people were wonderful, and they've been just as wonderful this time. We have, a small group here, so this will be sort of an informal discussion. While I would like to have the questions held until the end, if you just can't hold the question, I'll be glad to answer it during the course of the talk. Now, interesting, I got interested in attention deficit disorder as a result of the hysteria and stigma attached to cannabis in the United States, which is not much different than it is here in Australia. I had started practicing cannabinoid medicine in 2001, which was 5 years after the law had been changed in California to allow for the use of medical cannabis. And one of my patients, who I'd recommended cannabis for migraines, and also said, oh, by the way, he tells me that it is helpful in treating his attention deficit disorder. Got stopped in a forest by a forest ranger, and the forest ranger took his pipe, took his marijuana, and the young man showed the forest ranger my letter of recommendation, and the forest ranger gave him back his pipe, gave him back his marijuana, made a copy of the letter, and then sent it into the Medical Board of California with a cover letter saying, I think you should take appropriate action. I don't think there's anything wrong with this young man. Of course, the forest ranger probably hadn't even gone to forest ranger school, let alone gone to medical school. The medical board asked the patient to give up his right to privacy so that they could look at my medical records, and the patient told him to go jump in the lake. So then they issued an administrative subpoena. The story goes on and on. We finally won in a published decision. I mean, if you go on Google and look at Bearman versus Los Angeles County Superior Court, the court's determination was that the court that was underneath them, that they reversed, didn't understand the legalization law, they didn't understand my letter, they didn't understand the implementing legislation for the medical board, and they didn't understand the Constitution of the state of California. In other words, they couldn't have had it more wrong. Since one of the issues was attention deficit disorder, I didn't know whether I was going to win this appeal or not. I figured I might have to testify before the medical board, and that I better know more about attention deficit disorder than I did. This case dragged on for about 3 years, so over that period of time, I set my mind to learning a lot about attention deficit disorder. And so you're going to be sort of the beneficiaries, I guess, of the fear that was generated in me by the Medical Board of California wanting to subpoena a patient's records against the patient's will. So I've got a slide here, and oh, did you bring all the? Oh, good. So
Sorry, they're
we don't have
late.
a screen here, but we've got the things that have been run off here on the computer, so you can kind of follow along with my talk here. We got some more. Okay, I think we've got more than enough for everyone. Okay, so Voltaire said that doctors prescribe medicine of which they know little to cure diseases of which they know less on human beings of which they know nothing. And I think that comes close to reflecting what is happening in terms of the attempts to regulate cannabis. I mean, cannabis is a weed. And in 1937, the American Medical Association testified against the Marijuana Tax Act. They said, we don't know why you're calling this marijuana. We didn't even know that that's what you were talking about, cannabis. And they said, you're never going to be able to regulate it or control it because it's a weed. It grows wild. And that's a whole other lecture as to the motivation for trying to marginalize this incredibly effective drug. So in order to understand how cannabis works in terms of treating attention deficit disorder, post-traumatic stress disorder, and a number of other conditions, we need to understand how the endocannabinoid system works. We all make our own marijuana. The endocannabinoids that we know about are 2-AG and anandamide. And the grand old man of cannabis, medicinal cannabis, is Dr. Raphael Mechoulam, who is a scientist in Israel. He characterized the chemical structure of THC in 1964 and was amongst a group of scientists who characterized the endocannabinoid system in the late 1980s and early 1990s. One of the other things that I think is important, he has been involved in so many important scientific discoveries in regards to cannabis, is his hypothesis that there's something that he calls the entourage effect, which is the totality of the effect of all the therapeutic constituents in the plant. So recognize that as a plant, it has a lot of different chemicals in it, which is not strange or unusual or weird. I mean, that's what we have to get the authorities to take a look at cannabis as they would any other medicine or any other herbal preparation or any other food or any other nutraceutical, not to treat it as this unusual thing. What makes it unusual is the efforts that the governments around the world have made to marginalize this plant for a number of different reasons. Anyway, we have this endocannabinoid system, and Mechoulam in 1999 talked about the entourage effect. We've got 113 different cannabinoids in the plant, many of them that we know that have therapeutic value. We also have over 125 terpenes, and they're the thing that give the cannabis its unique odor, and many of the terpenes have therapeutic value. So we all have the endocannabinoids. We all have endocannabinoid receptors, not very creatively called the CB1 and the CB2 receptors. And we have a couple of enzymes that metabolize the endocannabinoids. We also have a couple of other neurotransmitters that are important to understand in thinking about attention deficit disorder and post-traumatic stress disorder. And those are dopamine and dopamine transporter. Now, there's one other concept that is critical. It's called retrograde inhibition. And basically, that's just a fancy way of saying slowing down the speed of neurotransmission, putting on the brakes on the speed of neurotransmission. All human characteristics are distributed on a bell-shaped curve, right? So some of us are going to have more endocannabinoids than others. Some of us are going to have more dopamines than others. And those of us that are, say, in the bottom quartile or the bottom 10% in terms of the number of cannabinoids we have are going to have our neurotransmissions going more rapidly than those who are, say, in the upper 50%. And when you have rapidly moving neurotransmissions, then you have difficulty in a number of areas. One is in focus and concentration, that is with attention deficit disorder. Another is in impulse control, and that, of course, is a symptom of post-traumatic stress disorder. So, we talked a little bit about the endocannabinoid system and a little bit about the endocannabinoid system's deficiency. Now, there's a whole bunch of comorbid conditions that can exist along with attention deficit disorder or post-traumatic stress disorder. They are all related to not having enough endocannabinoids, or maybe not having enough dopamine, or possibly having too much dopamine transporter, which ties up the dopamine. Okay, so what's going on here? And it's been a few days since I looked at this, so I'm going to be just as surprised as you are. Okay, so we've got a number of conditions that exist or can be caused by endocannabinoid deficiency. Post-traumatic stress disorder, anxiety, depression, autism spectrum disorder. There's a large number of things that we put labels on, diagnoses on, that are related to endocannabinoid deficiency syndrome. Now, people with attention deficit disorder probably don't have as many endocannabinoids as the average person. And so what happens is that you have these neural impulses that are moving basically more rapidly than the frontal cortex was designed to receive. So you've got 5, 10, 15, 20, a large number of ideas, concepts, sounds, colors that are just bombarding your cerebral cortex and making it difficult for you to focus and concentrate. By increasing the amount of cannabinoids, we can decrease the speed of neurotransmission. How does that happen? So you've got two neurons. Let's see, I think we're going to get into that maybe a little bit later, but let me talk about that now. So you have a neural impulse that's coming along on the presynaptic neuron. It gets to the synaptic cleft. If the action potential is high enough, it causes a release of a neurotransmitter. And then it goes on to the next neuron and stimulates that, and so on up to the brain. And that's the way we thought things worked until about the late 1980s or early 1990s, when these scientists discovered the endocannabinoids. And they come back from the postsynaptic neuron to the presynaptic neuron and cause a release of dopamine. And what the dopamine does is it causes a reversal of sodium and potassium from inside the cell to outside the cell, and it depolarizes the cell, making it more difficult for the next neural impulse coming along to stimulate that neuron. So why do we care? If we have fewer, slower moving neural impulses, that is, slower moving ideas, slower moving concepts, then there is a greater opportunity for the frontal cortex, the more civilized, more developed part of the brain, to grab onto, to focus and concentrate on one or two particular neural impulses that are coming in. Whereas if you have rapidly moving neural impulses, it's much more difficult for the brain to focus and concentrate. Now, I've been talking more about attention deficit disorder, and let me now talk briefly about post-traumatic stress disorder. So post-traumatic stress disorder can occur in anybody. I mean, it can occur in a person who's been in the theater of war. It can occur in a person that has been subjected to physical trauma or sexual trauma. It can occur in somebody that has grown up in a dysfunctional family. And what I think happens with post-traumatic stress disorder is that you increase the amount of dopamine transporter, and that this is a survival mechanism. And I tried to figure out why we had this system. And so this is what I came up with. This is out of my fertile brain. I can't say that it's backed up by a lot of science, but just assume for the sake of illustration that one of your ancestors and one of my ancestors is walking through a primeval forest, and a saber-toothed tiger comes along. And my ancestor stops and thinks, well, should I throw a spear at that saber-toothed tiger? Should I throw a rock at the saber-toothed tiger? Should I climb a tree? And about that time, the saber-toothed tiger has eaten my relative, too bad. But your relative has run away, was smart enough to run away. And their brain says, wait a minute. I do not want to get eaten by any saber-toothed tigers. And so it has this adjustment mechanism where it creates more dopamine transporters. So the next time that you see a saber-toothed tiger, you're going to have very rapidly moving neurotransmission, and you're going to get out of there very quickly. And so this is something that can be helpful when you come across an emergent situation, but it probably is a lot more helpful when you're dealing with saber-toothed tigers than when you're dealing with somebody who cuts you off on the freeway. Not a good idea, right, when somebody cuts you off on the freeway to, pull out your .44 and go after him and shoot him dead. You think about that maybe for a couple of nanoseconds until your cerebral cortex said, no, not a good idea, we're going to grandma's today and we'll be delayed. When you have rapidly moving neurotransmission, there are lots of different things that are affected by that. And one of the things is that you influence the midbrain, also called the reptilian brain, the most primitive part of the human brain, and it is concerned about survival. It's concerned about fight and flight. It's concerned about reproduction. It's concerned about some of the most basic aspects of human existence. And it sees the world in terms of life and death and black and white. So if there isn't time for the frontal lobes to exert some rational thought and say, wait a minute, things aren't quite as bad as you think they are. This is not a life or death situation. Okay, this lousy driver cuts you off, too bad, but it's not a matter of life and death. We're going to get to grandma's house okay, they didn't dent the car, relax. So when the midbrain is in charge, we tend to act first and think later. And one of the things I often use as an example in talking to my patients that have PTSD, I said, I'll bet you've had this experience where you've been having a friendly drink at the bar with a buddy of yours, and all of a sudden they push one of your hot buttons, and you call them an SOB and blah, 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 and pretty soon your friendly beer drinking afternoon is over. And about 2 hours later, you're sitting around thinking to yourself, why did I do that? I didn't want to do that. We were having a good time. And that's because the midbrain, the reptilian brain, was seeing this as a threat, and a much bigger threat than it really was. They were seeing it in terms of black and white, life and death. And so what the cannabis does, and what the endocannabinoid system does by being stimulated, is by slowing down the speed of neurotransmission, it allows the person with PTSD to get more into the present and to think more rationally, and not to have the midbrain running the show and sort of saying, remember, saber-toothed tiger might get you. No, the frontal cortex says, wait, the saber-toothed tigers have been dead for 10,000 years, I think I'm okay. And what I have found with people with post-traumatic stress disorder is that cannabis is able to treat many of the symptoms that are associated with that, which are being hyper alert, kind of always being cautious, having easy startle, having anger management problems, having impulse control issues, and having nightmares. And it's very useful for all of those. Now, not every person with PTSD gets relief for all of those symptoms. Most everybody with PTSD gets relief for one or more of those symptoms. And many of the patients that I see that have PTSD have been treated with a long laundry list of therapeutic substances with prescription medication, and they said, you know, it makes me feel like a zombie. And one of the things we need to recognize about cannabis is it's one of the safest therapeutic agents known to man. This was a determination, not that I made, but that was made by the Chief Administrative Law Judge of the Drug Enforcement Administration of the United States. So this is not somebody who was a big proponent of drug reform. He was just there to adjudicate what was going on. And NORML, the National Organization for Reform of Marijuana Law, in 1974 had submitted a petition to have cannabis rescheduled. And they delayed it for as long as they could, which was about 12 years. Then there was a 2-year rescheduling hearing that culminated in 1988. And Judge Francis Young, who was the DEA's Chief Administrative Law Judge, recommended rescheduling cannabis. Now, the reason we're talking here today is that George H.W. Bush's head of the DEA, one John Lawn, rejected the recommendation. And to back up his recommendation to reschedule cannabis, Judge Young, in his finding of fact, said that cannabis was one of the safest therapeutic agents known to man. And this is something that appeals greatly to physicians and, of course, even more so to patients. And you have these people with post-traumatic stress disorder who say, you know, this wasn't really treatment. This was sort of a pharmaceutical straitjacket that I was in. And I've been able to feel much more normal by using cannabis than by using the prescription medication that conventional medical medicine was recommending. We have some research with mice because of the activities of most governments, certainly including the government of the United States. Research on human beings has been blocked and been very limited. So we have to draw our conclusions from mice. And what they did in Germany at the Max Planck Institute was doing some research like that about a dozen years ago, in which they found that fearful memories were extinguished in these research animals after use of cannabis. So, I mean, that's one piece of science that we have to know that cannabis is useful in treating post-traumatic stress disorder. So, there's in the PowerPoint presentation that I have, I go into the different causes of PTSD, which I've mentioned were war and rape and that sort of thing. I've touched on the symptoms of post-traumatic stress disorder, which can also include anxiety and panic attacks and persistent frightening thoughts. Okay, so one of the things that we often overlook as a source for post-traumatic stress disorder is growing up in a dysfunctional family. And I don't know if you'd be surprised or not. I'm a little naive. I grew up in a small town in northern Wisconsin. Although I've lived in a lot of big cities since then, I think I still have that kind of small town way of looking at things. How many people grow up in dysfunctional families? How common emotional abuse is, how common sexual abuse is and physical abuse is. And growing up in a dysfunctional family is not much different than being in the theater of war. If you're a 2-year-old or a 3-year-old or a 4-year-old, you have no power. You have no strength. You're really a captive. You know, somebody could drop a bomb on you, or the equivalent of a bomb on you, as a 3-year-old or a 4-year-old. So there's no question, no reason to be surprised that children who grow up in dysfunctional families have PTSD. And what are their symptoms? Well, not too surprisingly, they're anxiety, impulsivity, aggression, hypervigilance, hyperactivity, depression, sleep difficulties. So you take a look at these kids that have so-called deportment problems or behavior problems, and a lot of times you find it's not really the kid's fault. It's not the kid's responsibility. They're reacting to the way in which they were treated, in a way that's unpredictable, in a way that uses affection as a manipulative tool rather than as a bona fide expression of concern and love. One of the concepts, one of the triggers for the symptoms of PTSD can be things which remind that person of the event, certain places, situations, and smells, which also probably would be reminding the person of the event, movies or TV about war. I have one patient with PTSD, and I saw him just last week, and he's much better than he was the first time I saw him. This gentleman lives about 10 miles outside of a small town that's at the edge of nowhere called Bishop, California, and he lives at the end of the road. And he told me when I first saw him, it's a good thing for cannabis because if he wouldn't use it when he went into town, he would start shooting people. And he said at that time that he only went into town about once a month because he had a difficult time being around people. So people can cause anxiety, particularly, in people with post-traumatic stress disorder. People getting too close can be a problem. I remember a conference that I went to when I was just out of my internship, and one of the presenters had been a doctor in a federal prison, and he talked about the concept of a body buffer zone. You might try this at a cocktail party, sort of for the fun of it, and start, when you're having a conversation with one of the other guests, slowly move closer to them and see how close you can get to them before they say, "What the hell are you doing?" You've invaded their body buffer zone. So what this doctor said is that as a piece of research, he would take various inmates in a small room, maybe 12 by 12, maybe 20 by 20, and set them in a chair in the middle of the room. And then he would stand against the wall, and the instruction he gave is, I'm going to slowly walk towards you and you tell me when I'm too close. And what he said is that those people who were guilty of aggressive kinds of crimes, such as murder or assault, you couldn't get very close to them. As a matter of fact, he said that several of the murderers said when he was standing against the wall, that's close enough, I'm uncomfortable. Now, people, I think, are more likely to become murderers if they get treated like shit when they're children. It seems to me that one of the best things that we can do in terms of, quote, drug abuse prevention is to have every child be a wanted child and a loved child, and to teach people how to be good parents. The sad thing is that the prohibitionists and the neo-prohibitionists, some of the stuff they talk about is actually worth doing, except they're unwilling to spend any money to do it. And they'll block teaching people how to be good parents. And in fact, they'll take people's children away because they're using cannabis maybe to treat their PTSD. No reason for that, absolutely none. I've testified numerous times at trials put on to get kids back from Child Protective Services. So there's a variety of treatments conventional treatments for PTSD, which include medication and counseling or a combination of the two. One other thing that I found is helpful for some people is extraocular eye movement reprogramming, which desensitization and reprogramming. And what this is stimulating both sides of the brain at the same time, and somehow it integrates the idea that you're no longer in the stressful situation and that you are in control of the situation that you're currently in. I had a Vietnam War veteran who had agoraphobia that I saw for several years, and then he was afraid to go out of the house. He couldn't drive a half hour to go see his grandchildren. And he came in and saw me about 6 years ago and said that he and his wife had just gotten back from a trip to Alaska. And I said, well, what happened? He said, I had this EMDR. And I've had a couple of other patients that have had success with that. And the nice thing about EMDR is there's no medicine. It's basically just we're going to put some flashing lights. We're going to flash one here, we're going to flash one there, and it's going to make both sides of your brain work at the same time. Some of the common medications, yes.
What does it stand for?
Extraocular eye movement reprogramming and desensitization.
Right.
Eye movement.
Extraocular eye movement desensitization and reprogramming. Okay, so there are common medications in which I mentioned to you that some of the people with PTSD say, hey, it makes me feel like a zombie. Here's a bunch of antidepressants that are thrown at people: Lexapro, Paxil, Effexor, and then you have some other things that are called mood stabilizers, Zymbalta and Abilify. And sometimes people are on 2 or 3 of these at the same time. So it's really no surprise to me, and I'm sure to you, that for a lot of people, it's no better than having the symptoms of the PTSD. One of the things that we try to do in medicine with any treatment is to balance the therapeutic effects versus the side effects. I'm going to be talking in the town hall at 2:30 on cancer. And when you have cancer, the treatment, the side effects are significant. They're vicious. And we wouldn't do that, or I think medicine wouldn't do that, if we didn't think we were treating a life-threatening illness of cancer. Now, the sad part of that story, which I'll go into in an hour or two, is that you don't get many side effects when you're treating cancer with cannabis. And you can treat cancer with cannabis, but as a Western-trained physician, what I feel compelled to say, to make the Medical Board of California happy, is that you should only use cannabis for cancer in conjunction with conventional treatment. So when we're treating somebody with PTSD or attention deficit disorder, I was talking to Rob Lurie, who is one of your speakers here, and he spoke yesterday, and he said, look, I've got attention deficit hyperactivity disorder. They gave me Ritalin until 8 years old, and when I was 8 years old, I stood up to my parents and said, I don't want to take this anymore. And what happens with Ritalin? Well, the side effects of Ritalin are it interferes with your sleep, it interferes with your appetite, and makes you jittery. What are the side effects of cannabis? It helps you sleep, stimulates your appetite, and treats your anxiety. So I have patients with attention deficit disorder who are treated with just cannabis, or with a combination of cannabis and with these sympathomimetic drugs like Ritalin or Dexatrine or Adderall that some of you may have heard of. Okay, so the side effects versus the therapeutic effects is, I think, a critical element with cannabis because the side effects are so benign. What are the side effects? Well, most of the time that people have side effects, it's from either taking too much or taking it before you know what you're doing. A good example of both of those things is there's a columnist for the New York Times named Maureen Dowd, who about a year and a half ago or 2 years ago was going to write an article about the recreational drug legalization of cannabis in Colorado. So she went to Colorado, she went to a dispensary, she got a candy bar. The candy bar had 150 milligrams of THC and about 1 milligram of CBD. So it was calculated to get you pretty high. But it was also scored into more reasonable dosages. So it was like a 10 milligram dose or a 15 milligram dose. And so what this reporter did is she broke off one of the 10 milligram dosages and ate it. Now, if you take cannabis orally, it's going to take 45 minutes to an hour and 15 minutes before you have either the therapeutic effect or the recreational effect. So she waited 15 minutes, and of course nothing happened. She broke off another piece, waited another 15 minutes, and nothing happened. So she ate the whole thing. And she was miserable for 6 hours. So the point is, these things are dose-related and, to a certain extent, strain-related. So it's important to know what you're doing. You know, when the doctor gives you a prescription for sleeping pills, you don't take the whole damn bottle at once. You know, you take it as prescribed. So this person didn't know what they're doing. Now, one of the other side effects that we've heard more about lately with the onset of legalization of recreational use in several states is seeing an increase of what's called hyperemesis. And hyperemesis means throwing up a lot. It's not that uncommon for something that a medication treats, for if you take it in too high a dose, for it to actually cause that very same symptom, and that's the situation with hyperemesis. I mean, the point with cannabis is that if you're using it medicinally, your goal is to treat the symptoms, to treat the medical condition with the lowest possible dose and having the fewest side effects, which is really the opposite goal of using cannabis recreationally. When you're using it recreationally, the idea is to get high. And for most people, the higher the better. So very few of the patients that I've seen, and I've been practicing cannabinoid medicine since 2001, and I've seen many of these patients for 10 or 15 years, few of them have any side effects at all. Now, probably the most common side effect is euphoria. And I do have some patients who say, I don't smoke marijuana until after I get home from work. I use it sort of to calm down, like maybe another person might drink a martini. Because I think that it might interfere with my driving. I'm not so sure if I'm thinking so sharp. So, I mean, that can be a side effect. But like all side effects, it only affects some people. Most people can drive. Doesn't interfere with their driving. And in fact, the U.S. Food and Drug Administration says about THC, the euphorogenic agent in cannabis, which is dronabinol, a prescription drug that's been on the market for 30 years, and they have the conventional warning for a psychoactive drug. It says, warning, don't drive, operate heavy equipment, or engage in dangerous activity until you determine whether or not this interferes with those activities. It doesn't say, oh, if you have more than 5 nanograms per milliliter of THC, you shouldn't drive. It doesn't say anything like that at all. It's very common sense. If it doesn't interfere with your driving, well, hey, go ahead and drive. Okay, so those are some of the some of the side effects of cannabis. I mean, you can have a panic attack, particularly if you haven't experienced it much, and that's exactly what Maureen Dowd experienced. You can have this hyperemesis. You can feel drowsy, you can feel dizzy. Now, one of the side effects with dronabinol, which I have never seen with cannabis, is it can actually cause seizures. And of course, we know that cannabis is very effective at preventing seizures. So those are really the main side effects. And to look at cannabis as a dangerous drug is to ignore certainly the last 30 years of science and the last 4,000 years of medicine. Okay. So I think we've talked about dopamine, we've talked about the midbrain, we've talked about anandamide, we've talked about retrograde transmission, we've talked about the dopamine model of PTSD. Okay, we've talked about how things work in synapse. Okay, so you heard me talk about endocannabinoids. Okay, she's given me the high sign here, which means there's going to be 15 minutes left, and there'll be time for questions and answers. So let me try to wrap it up in the next 2 or 3 minutes here. So we've talked about how cannabis works to treat PTSD. It works by slowing down the speed of neurotransmission. It works by allowing the frontal cortex to have more say-so in our actions than the midbrain. It allows us the opportunity to think first and act later rather than to act first and think later. Okay. There is some PTSD research that's going on, and I think I will end with that. And that is being done by Dr. Susan Sicily. And again, to show you how crazy we are in the United States, that your politicians are no more crazier than ours, although I think that Donald Trump is setting the bar pretty high in terms of craziness. But at any rate, she had one of the few people that had gotten the permission of our federal government to do research with actual cannabis, with actual marijuana. And she had jumped through all the appropriate hoops. And then there was a state senator in Arizona, she was in Arizona, and they said to the University of Arizona, where Dr. Sicily worked, they either said, we're not giving you any money for Dr. Sicily, or they said, if you allow Dr. Sicily to keep working there, we're not giving you any money for anything. So that was the end of Dr. Sicily working at the University of Arizona. Fortunately, she's in Colorado, she's being privately funded, and she's carrying out her research with the use of cannabis to treat PTSD. And you know, the point is that we know from experience that cannabis is useful in treating attention deficit disorder, post-traumatic stress disorder, and I didn't even get a chance to segue into autism and autism spectrum disorder, but I have been really amazed at the way that it's helped control aggression and impulse control in kids with autism, and the very positive feedback that I've gotten from parents of autistic children. So I'm going to take a deep breath here and turn it over to the audience and see if somebody has a question. Yes. Oh, and I'm going to ask you, talk louder than you normally would because I'm deaf as a post.
Oh, okay. Look, I'm a bit deaf too, so I understand. I work with people with brain injury, acquired brain injury. Did you understand that? Oh, come closer.
Say again.
I work with people with acquired brain injury. One of my clients is on and has been on Valium,
right?
A small dose of Valium,
right,
to control his impulsiveness and everything. But
right.
What you're saying about this slowing the impulsiveness
right.
and letting your brain figure it out before you.
Right.
This sounds to me like it will be a perfect substitute for.
Yes.
For Valium, or even in combination with.
Exactly. It doesn't need to be an either-or situation. He mentioned Valium, which is a benzodiazepine, and years ago, one of the first really neat consulting gigs I got, a drug company called Hoffman-LaRoche, which makes Librium and Valium, called together 43 of the top drug abuse treatment experts in the United States. I'm pretty sure I was number 43 because they called me up about 3 days before the conference. But anyway, I went anyhow. And we told them that doctors really didn't know what they were doing when it came to prescribing benzodiazepines because they can be very habituated. You can have long-term significant side effects from benzodiazepines. They're really designed to be used intermittently for, say, a couple of days, a couple of weeks, maybe a couple of months. Now, they're very seductive, and as a physician, I found myself doing the same kinds of things that I said don't do, which is prescribing Valium on a regular basis. And I haven't seen too much difficulty, but there are problems with that. If a person wants to stop taking a benzodiazepine, they have to taper off that much more slowly than, say, you would have to taper off something, an opiate like heroin. So the answer to your question is, Valium is an anti-anxiety drug. Cannabis is an anti-anxiety drug. The second most common reason for cannabinoid medicine specialists to recommend cannabis in California is to treat anxiety. So the answer to your question is yes, either alone or in combination. I saw a hand up back there, and again, speak really loudly because I'm very deaf.
One of the complex problems with Valium is that you can take 1 or 2 Valium tablets and a week later your blood will detect diazepam, oxyzepam and nitrozepam, which are all blood down close, but they're also individual drugs in the same family described as well.
I missed part of that. What's the
The
concern?
Valium will break down in the system naturally through oxyzepan, nitrozepan and diazepan. So you actually have all those three drugs can be detected in your blood just from taking 2 Valium tablets 10 days ago.
Right, but I think what
you're
the
actually affected by all those breakdown products that also are prescribed individually.
Right, I think the point that you're getting at is that whenever you take a drug, it doesn't stay in the form that you swallowed it. It's metabolized into a number of intermediate metabolites. And so when you take one benzodiazepine, that will soon be metabolized into 2 or 3 different metabolites, and you'll test positive for them. Now, in terms of drug testing, in the toxicology report, at least in the U.S., and I assume that it's the same standard all over the world, is they're not testing for what drug is in you. They're testing to see if you're taking any illicit drug. So if you have, say, a prescription for Norco, which is an opiate, and you test positive for hydrocodone, that's reported as a negative. And relevant to cannabis, the toxicology screen is not for cannabis, it's for THC. Why is that important to us? It's important to us because there's a drug in the States called dronabinol, and there's a drug I think is available here in Australia called nabilone, which are synthetic THC. And so you have a prescription for nabilone, or you have a prescription for dronabinol, and you test positive for THC, that's reported as a negative. And that, I've seen that happen in the States. One of my patients had a prescription for Marinol, tested positive for THC, didn't get a job that he applied for, sued the company, and got a $20,000 settlement. You know, he had to go through all that aggravation and stuff. But, so that's, you know, the toxicology screen is interesting. I think I saw your hand go up first, and then...
I think theirs was up first.
You were first? Okay. And scream at me.
Okay. Right. So if this is in relation to autism?
Say again?
Autism?
Autism, yes.
Okay, do you use an...
Why don't you step real close? I mean, okay, thank you.
That's right.
Yeah.
Okay, so with autism, do you use an integrated approach alongside the cannabis, and is there a particular kind of cannabinoid that you find more effective than others?
Good question. The question was, do I use an integrated approach, and is there a particular strain or a particular ratio of THC to CBD? Generally, what's happened so far with the autism situation is I'm not an autism expert, and in most cases, these children are already being seen in special education courses, and being as how Santa Barbara is kind of a upper middle class upscale place, there are a number of different treatment modalities that are available, and many of these children are receiving that. You know, the idea of my learning more about how to integrate some other treatments into this, I'll take that as a suggestion because I don't currently do that. Now, the question that you brought up about, gee, what's the right dose to use here is something that's very frustrating to me, and I actually was thinking of touching on that earlier because there's an enormous amount that we don't know. Okay, I'm here as a so-called expert, right? And I can tell you what I don't know, which would fill this tent, as opposed to what I do know, which, well, fills my book here. And the strains, we're all different, okay? And so you've got this variability in humans, and then you have the cannabis, which has been genetically modified and which has been grown largely for the recreational market. And of course the research has been suppressed or put into a pigeonhole, so we don't know. And all I have is the experience, you know, and the research. There has not been a lot of research, certainly not any human research on autism, and very few mice have autism. So it's, you know, it's kind of hard to figure it out from that. And the feedback that I've gotten is all over the map. I had one young man, a 16 or 17-year-old fella. He and his mother came from the middle of the U.S., from Minnesota, and he had social anxiety. There's this whole spectrum called the autism spectrum disorder. People who have very severe autism, I mean, they're pretty much uncontrollable, to people who have just a lot of anxiety or have social anxiety. And I wrote him a prescription for dronabinol, which is 511 chemicals short of marijuana. But I had to do that because Minnesota wasn't a legal marijuana state. And they came out the next year, so I assumed that meant that worked. On the other hand, it was a very low dose, 2.5 milligrams of THC 3 times a day. Then I had another fellow come in whose father was a contemporary of mine and another physician, and this man's 18-year-old son, who had pretty severe autism. I mean, I'd have to examine each patient that I see, again, in order to keep myself straight with the authorities, and he brought his son in, and he became very, very uncomfortable with this stranger and just in a strange place. And within a few minutes, his father removed him to his special education class in the school that was only about a 5-minute drive away. And they had given him 25 milligrams of CBD a couple of nights earlier and said, boy, this stuff worked really well. Now, if we go back just a few years, nobody really heard about CBD. And so most of the studies that have been done have really been done with THC, with fairly modest doses of THC. I mean, the fact is that you absolutely don't have to get higher than a kite for cannabis to be effective. Relatively low doses of cannabis can be effective. And I usually tell people, look, why don't we do a 1-to-1? And the reason I go with the 1-to-1 is that we have all of this experience with nabiximols. Also, the trade name is Sativex, made by a UK company, GW Pharmaceuticals, and they have found that there are very few side effects with that. And I say, okay, look, why don't we start off with 5 milligrams of each and see what happens. And then, as with anything else with cannabis, you start with a low dose and you slowly increase the dose. So if you have a child with autism, or you know somebody that does, and you've been experimenting with what the right dose is, you probably know more than anybody else in the world. You know, you're on the cutting edge, and on the one hand that's encouraging, on the other hand it's depressing that we don't have a lot of scientists that have been out there looking into this so that we don't have to be our own guinea pig. But thank you very much for that question. It was excellent. And you had the next question.
Yeah, so I'm a medical doctor as well. I work in obstetrics and gynecology and general practice. One of the things you said earlier, which I agree with, was the idea of looking at the effects of the combinations of different chemicals within cannabis, which kind of goes against Western medicine in a lot of ways, because which looks at isolating individual chemicals, maybe giving 1 or 2 together.
Yes.
And I think pharmaceutical companies are interested in only things that they can copyright. So coming up with some synthetic, cannabinoid that they can copyright that maybe has therapeutic effects.
Right.
When I was an intern, I worked in a psychiatric ward, and one of the things that was, one of the arguments against cannabis legalization that's often used is the examples of people who have drug-induced psychosis from using marijuana.
Yeah, okay. Let's get into that. First off, I would suggest for everybody in the audience that is interested or concerned about that to read Dr. Chris Fitchner's book, Cannabinomics, the Marijuana Tipping Point. Dr. Fitchner is currently on the faculty in the Department of Psychiatry at the University of California at Riverside School of Medicine. Previously was the director of the Illinois State Department of Mental Health. And he and I have kind of had an ongoing discussion as to whether or not there really is any real data about cannabis and schizophrenia, because cannabis has also been found to be a very good treatment for psychosis, okay? And one would think that if cannabis caused schizophrenia, that depending on what lag time you thought there was, sometime in the 60s or 70s or 80s, if we were following the trend of the percentage of people that have schizophrenia, there should be a sharp spike in there. And in fact, there's been an almost level or maybe a gradual decrease in the incidence of schizophrenia. Now, one of the things that there may be some evidence on is that for people who are going to get schizophrenia anyway, I don't know how you know that, but people are going to get schizophrenia anyway, that the use of cannabis may bring it on sooner. But this is really another scare tactic to which the data is limited and ambiguous. And there's no, I think if you read Dr. Fitchner's book, you'll be impressed with his knowledge of the literature and also with the amount of ambiguity that is associated with this so-called connection between cannabis use and triggering schizophrenia.
Yeah, right. Well, one of the things that I experienced was that the synthetic cannabinoids that people smoke because it doesn't show up in a drug test.
Oh, it does show up in the drug test.
The ones that, like the chronic and things like that, seems to be associated with more so with, at least that's
yes,
that was,
wonderful point. I'm glad you made that point. If you take a look at dronabinol or marinol or nabilone, whatever, what I tell my patients is that it costs more, has more side effects, and doesn't work as well as marijuana. So why do I prescribe it? Okay, so the reason that I prescribe it is, number one, for most people it does work, even though it doesn't work as well as marijuana. Also, because of the stigma attached to it, particularly people of a certain age, they feel uncomfortable going into a dispensary and they'd rather go into a pharmacy. And also, I know what dose you're getting. If I prescribe 2.5 milligrams of dronabinol, you're going to get 2.5 milligrams. If I say, go down and get an edible at the dispensary, maybe you'll get 2.5 milligrams and maybe you won't. Then the other thing is that I've noticed a slight increase, maybe 10%, 20% of insurance companies will cover dronabinol for off-label indications. It has very narrow on-label indications, and so people appreciate the fact that their insurance company is going to pay for this rather than they're going to have to dig into their own pocket. But there's no question that cannabis is more effective than the synthetics, and I appreciate that. By the way, seeing as you're a physician, this gives me the opportunity to mention the American Academy of Cannabinoid Medicine, and we'll be happy to let Australians have something called the Australian Academy of Cannabinoid Medicine, because we won't even have to change the initials. So I'm going to give you this and hope that you will consider joining our organization. I see you waving that around. Does that mean that I'm reaching the end of my time here?
I'm the ventilator.
Okay, all right. So, are there other questions here?
Could you just tell me the name of the book, Chris Kitchener's book?
Oh, Dr. Fitchner's book?
Yep.
It's a word that he coined called cannabinomics.
Cannabinomics.
Yes, and where Dr. Fitchner came up with cannabinomics was that when he was the director of the Illinois Department of Mental Health, he reckoned that people were using cannabis instead of prescription antipsychotics, that it would be cheaper, there would be fewer side effects, it would be more effective, and it would be a way of stretching his budget to do more things for more people. And so he was looking at both the therapeutic effectiveness as well as the economic effectiveness. And I have testified at hearings with Dr. Fitchner, and he is very good, he's very academic, he's very thorough, and he's quite balanced. And like I say, he and I have a slight difference of opinion in that he thinks that there may be a minimal, not really statistically important effect in terms of schizophrenia. And I look at the epidemiology. I've had a lot of experience in public health, and I say, hey, I don't see those spikes there in 1970 or 1980. Okay, one last question or comment, and yes, come up here and whisper in my ear.
I've seen examples of non-inherited drug psychosis where children, and they're all parents warning children not to eat poisonous matches or various sorts of berries. Well, I experienced a young man who used to eat these cantaniester red berries and get stoned when he was about 4 years old. He did it for 2 or 3 years until his parents moved and never had them again. But during that gaga stage, he did it because of the altered state of mind he was unknowingly giving himself and enjoying that state. Now, many years later, he was quite normal, but if he had a beer or a bit of cannabis, he went straight back to that psychosis gaga stage and just literally acted like a 2-year-old baby while he was using cannabis and alcohol. If he didn't use those substances, he was 100% normal, because that was brain damage done by altering the state of mind as a child, and it stayed there during that developmental stage.
I couldn't disagree with you more.
You have inherited too, but that's not inherited psychosis.
Well, we have, I think one of the more, as I'll mention in my talk on cancer, one of the more remarkable cases was a 15-month-old child who had an inoperable brain tumor at the base of his brain. The surgical oncologist said, I'm not going to do surgery because if I do, the child will be a vegetable or he will die on the table. And so the parents had really no option. We're working with a lay healer as well as a physician. Physician's name is Jeff Hergenrather. He's in Sebastopol, California. And this child got a gram of concentrated cannabis every day. That's about 250 milligrams of THC. And according to Dr. Hergenrather, he was a normal child. He was happy as a clam. He had no side effects. Oh, and just as an aside, his tumor went from the size of a tangerine to the size of a pencil line. And I think we're busy freeing the weed here, and I'm going to conclude by inviting you up to my talk on cancer at 2:30, and even more importantly, to my book signing at 3:30, and spending lots of money on the book and making me rich and famous. I want to thank you very much for your attention. I want to thank you for your questions. It's always a pleasure to come to Nimbin, and I hope to come back here many more times. Thank you very much for having me.